Good morning. Thank you, Dr. Pollack, for the introduction. And I'd like to thank the program committee for this opportunity to present our work today. I'm one of the surgical oncology fellows at MD Anderson. We have no disclosures. Pancreatic cancer is a third leading cause of cancer death in the United States, with a 5-year survival rate of approximately 8% for all comers. Even for minority of the patients who are eligible to undergo resection, most large published series show a median overall survival of approximately 2 years. Multiple randomized controlled trials have shown that systemic therapy is a critical component of multimodality treatment for pancreatic adenocarcinoma. As you can see on this graph on the right, 6 months of adjuvant gemcitabine chemotherapy improved overall survival compared to surgery alone. However, approximately up to half of the patients in the United States do not receive adjuvant therapy, largely due to poor performance status following surgery. Neoadjuvant therapy is becoming more prevalent for treatment of pancreatic cancer, and this was nicely highlighted in this morning's session on borderline pancreatic cancer treatment. Neoadjuvant therapy has the potential to decrease the burden of disease found at final pathology. It also ensures delivery of multimodality therapy. And perhaps most importantly, it allows you time to select out patients who may not benefit from surgical resection and have early metastases. Therefore, some institutions, including ours, have long been a strong proponent of this neoadjuvant approach. Last year, one of our previous fellows have nicely summarized our 25-year institutional experience of using neoadjuvant therapy. As you can see in this graph, in our latest study period highlighted in the purple line, our median overall survival using this approach is now up to 43 months. And this compares favorably to contemporary national median overall survival of about 2 years using the surgery first approach. However, there is still a debate due to relative paucity of level 1 data whether neoadjuvant therapy is really necessary for early stage or clearly resectable pancreatic cancer. The goals in our study were first to study the national utilization rates of neoadjuvant therapy in stage 1 and 2 pancreatic adenocarcinoma, and secondly, to analyze the rates and impact of pathologic stage migration for these cohort treated with surgery first versus neoadjuvant therapy approaches. To do this, we utilize the National Cancer Database, which is a hospital-based clinical cancer registry that captures more than 70% of all newly diagnosed cancers in the United States. Of approximately 240,000 pancreatic cancer patients in this database, we selected patients who had undergone pancreatic duodenectomy procedure between 2006 and 2013 for clinical stage 1 or 2 disease and had complete pathologic staging and known treatment sequencing information. Of approximately 14,000 patients in our overall cohort, a vast majority, approximately 12,000 patients, had undergone surgery first, and just over 2,000 patients had undergone neoadjuvant therapy followed by surgery. First, we looked at the overall trends in the use of neoadjuvant therapy. As you can see in this graph, that neoadjuvant therapy usage increased from approximately 10% to approximately 20% through our study period. But the overall proportion of the patients receiving neoadjuvant therapy is low at approximately 15%. When we compare the preoperative clinical factors between these two groups, we found that neoadjuvant therapy was utilized more frequently in more advanced T stages. Despite the fact that neoadjuvant therapy is more often utilized in more advanced cases, neoadjuvant therapy patients had lower rates of pathologic nodal metastases. This figure on the left shows that lymph node positivity rate is considerably higher in surgery first group at 69%, compared to only 46% in the neoadjuvant group. This pattern is pretty consistent across all the published studies. In addition, neoadjuvant therapy group had higher rates of margin-negative resection, as shown on the graph on the right. When we compare the final pathologic stages between the two groups, we saw that higher proportion of neoadjuvant patients were staged as having stage 1 or 2A disease, whereas most of the surgery first group were staged as having stage 2B or 3 disease. We then examined the rates of stage migration between the initial clinical stage and the final pathologic stage. So when clinical stage 1 patient undergoes the surgery first approach, 65% of them, highlighted in the red bar on the left, were upstaged to stage 2 or higher. This upstage rate was significantly lower in the neoadjuvant group at 46%. Similarly, when clinical stage 2 patients underwent surgery first, 33% were upstaged to stage 3 or higher, while only 14% were upstaged following neoadjuvant therapy. In addition, approximately 40% of the stage 2 patients were downstaged to stage 1 using the new AJCC 8th staging guidelines, compared to 18% in the surgery first group. When we stratified patient survival by treatment sequencing, we noted that neoadjuvant therapy patients had slightly better survival compared to surgery first patients who were able to receive the adjuvant therapy. And both of these groups had significantly better survival compared to surgery-only group. So in summary, only 15% of the national cohort in our study received neoadjuvant therapy during our study period. While neoadjuvant therapy cohort had higher clinical T stages going into surgery, they had lower rates of lymph node positive disease and margin positivity. Neoadjuvant therapy was associated with decreased rates of pathologic upstaging in both clinical stages 1 and 2, and higher rates of pathologic downstaging in clinical stage 2. Finally, neoadjuvant therapy was associated with improved overall survival. So in conclusion, preoperative clinical staging for resectable pancreatic cancer severely underestimates the true local regional disease burden. Neoadjuvant therapy decreases rates of bad surprises on final pathology, including margin positivity, lymph node metastases, and pathologic upstaging, and is associated with improved overall survival. And we feel that neoadjuvant therapy, therefore, should be considered for all pancreatic cancer patients, including those with early stage resectable anatomy. And I would like to just thank Dr. Cameron for making this point for us earlier. Thank you for your attention. I'd like to thank my co-authors as well as my mentor, Dr. Qingwei Zhang. Thank you.
So great presentation. Professor Hackert from Germany will discuss.
Dr. Lee, thanks for presenting. Microphone? Okay, thanks for presenting and for sending your manuscript in advance. Of course, I think that the conclusion of the study is a little bit dangerous to extend this to 1 and 2 in general. The problem is you have a problem with the staging. You have seen that 30% of the staging was simply not correct, and the stage 3 and 4 patients had been operated up front, and they should not have done that. So the first question is, what do you think we can improve the staging? What can we do to improve the staging? The second thing is you have a cutoff of CA99 in your manuscript of 37 as the regular cutoff. Do you think that it's sensible to make more cutoff levels like 100 or 400 as it was shown in other papers? And the third question I have is the resection margin. You have community hospitals, you have university centers, and you have only R0 and R1. Do you think that the resection margin specification, more detailed, will give a second thing on your conclusion, and that this may be a confounding factor in your study? Thank you.
Thank you. Thank you for your question. So to address your first question about clinical staging, we completely agree that given the current imaging techniques we have, the clinical staging although we do it for document purposes, is not that useful in pancreatic cancer. And that probably explains the high upstage rates that we saw in our study. But it sort of helps us make our point where, we're 70% of the patients consistently have shown to have lymph node positive disease and have more advanced disease. And so we feel that everybody with pancreatic cancer should get some neoadjuvant therapy. As far as your second question about CA19-9, I agree with your assessment that the data presented with that cutoff level may not be appropriate, and we can certainly go back to our database and address your question. And finally, as far as the location of the treatment center differential, certainly many studies have shown improved survival in high volume academic centers. And in my previous look at this database that has similar patterns have shown that, we can certainly try to include that in our analysis for the paper.
So thank you. So I think with that, I'd like to thank my co-moderator, Professor Christofi. I'd like to thank all the speakers, and I'd like to thank all of you for your attention today. Thank you.